Houston Methodist and DeBakey CV Live. It's Dr. Randall Wolf here. First Tuesday of each month, with a few exceptions, taking off in summertime. First Tuesday at 5 p.m. Central Time, we present this. We're talking about atrial fibrillation. We've got a really exciting program for you today. Many of you have asked questions about the results of the procedure, and we put together a presentation for you. We'll talk about the procedure and then go into some detail about the results of an ongoing study. With me here is Dr. CK. His first name is Marcel. I call him Marcy because it's a lot easier to pronounce than his Hungarian last name. Also, you'll see on here when we present, you'll see Dr. Miranda's name. He was instrumental in helping us put together the protocol for a manuscript that we have that we're going to send for a publication. This procedure first started over 20 years ago, 23 years to be exact, and the impetus was we had developed a radiofrequency clamp so patients who were undergoing open heart surgery could have their atrial fibrillation addressed at the same time if they had atrial fibrillation. The clamp was successful, was used by surgeons, including myself, to treat atrial fibrillation at the time of open heart surgery. But my secondary goal was to be able to treat patients that weren't undergoing open heart surgery, but still could benefit from this type of technology and a procedure that could possibly end the patient's journey with atrial fibrillation. We were successful in the laboratory and then ultimately in patients starting in 2003. I still have some patients that I follow every year that are now 22 to 23 years out from the procedure and still AFib free. It also became clear over time that we needed to follow the patients and report the results in a very objective way. Fortunately, I had been using an implantable monitor in the majority of the patients, probably over 90% of the patients. Any patients where their insurance would pay for the implantable monitor, any patients who were over 65, where Medicare would automatically pay for the monitor. And initially the monitors would give us an EKG every day for 3 years. So the battery life was 3 years. Now it's been improved to a battery life of 5 years. But we had a substantial number of patients who had the implant at the time of the Wolf procedure, and we felt it was appropriate to interrogate these implants to see what the real results were of the procedure. Now, I think to preface this, I have to say that this is very unusual to have a large series of patients, starting out over 500, who had the procedure and an implant. These implants are generally not done with catheter ablation. They're generally not done with AFib procedures with concomitant surgery. But it gave us a unique opportunity to see what the real results were very objectively, not an EKG at 1 year. Maybe the patient would be in AFib, maybe not, but an EKG essentially every day and monitoring the AFib burden. And we think that's much more important than whether or not there's an episode of AFib. So the Link monitor from Medtronic, that's what most of these patients had. I think some may have also had the Abbott monitor. Most of them were Medtronic. But these monitors keep track of the AFib burden per month. Is it 100%? That would mean the patient's out of rhythm all the time. Is it 0%? That means the patients would be in rhythm all the time. Or is it somewhere in between? And we determined that less than 2% burden was a good cutoff. Those are patients that pretty much were in rhythm all the time. Now, I think it's probably also appropriate, since we're going to talk about results, to first talk about the procedure and how it's done. There is opportunity for you to opine or ask questions. So, Mr. Producers, let's go to the slide that shows everybody how to tune in and send a question. If you're on your phone, go to 37607 and then text DeBakey. If you're on your computer, go to pollev, that's POLLEV.com. You'll see it on the screen there. Enter DeBakey and ask your question. Again, if you're on your phone, 37607, text DeBakey. If you're on a computer, pollev.com, enter DeBakey. And I encourage you to ask your questions early in the hour, because we really would love to get to all your questions. So if you have a question, take a second, send it to us now so we can get to it before the end of the hour. The data collection was done very objectively. I say that because I was not involved with the data collection of these, what started out as over 500 patients. And that fell to Marcel. Marcel did the data collection, and he also put together this data into a body of information that we're preparing for a manuscript. So I think it's appropriate this time to talk about the procedure by introducing Marcel, and we'll go to the slides that Marcy has, and he'll use those as way of introduction and also for the presentation. So can we go to the slides now? Is that it? Yeah, I think you're up there. It. Okay.
Yeah.
And can you do a split screen so they can see Dr. CK? All right.
Well,
Marcy, why don't you begin presenting?
Thank you very much. First of all, I'd like to thank you for the invitation for this CV education webinar, and also it's a pleasure to work with you as well in research and also with Dr. Reardon. So I'm coming from an institution from Budapest, Hungary. This is the Central Hospital of Northern Pest. I'm a third-year resident, a PhD fellow, and right now I'm a clinical research fellow as well at Houston Methodist Hospital, CV surgery department. I'm coming from an institution which is probably the busiest heart surgical institution in Hungary. We do around 1,000 cases per year. We do a lot of minimally invasive cases as well. So it is, I think, is a very good institution to train in. First, I would like to show you the surgical video, what Dr. Wolf mentioned. Please enjoy it.
Dr. Randall Wolf here, Houston Methodist Hospital, DeBakey Heart and Vascular Center. I'm the arrhythmia specialist. And today, you get a special look at the important details of the mini-maze procedure. And here we are with the patient right side up on a beanbag. There's a double lumen endotracheal tube. The patient had been in AFib for 4 to 5 years. Pre-op echo and CT scan were performed. Very large left atrium, 196 milliliters. If it's greater than 200 milliliters, then the chances of staying in rhythm start to go down. And now we're doing the remainder of the prepping and draping to begin the right side. This shows the freehold device. It holds the diaphragm down, particularly in obese patients, and gives us a better picture. It's easy to use, often used for liver, retracting the liver, but it's good for this. The next step is to open the pericardium anterior and parallel to the right phrenic nerve. There's a little fat pad, the edge of the fat pad of the phrenic nerve. There's the phrenic nerve. I do this with cautery on 30-30. That's what I always use, is 30. We can open the pericardium all the way up above the superior vena cava to where we see the aorta. Here we're putting in pericardial stays on the right side. Don't pick up on the phrenic. Don't put the needle through the phrenic. This is a technique of pulling the pericardial retraction sutures between the ribs using a Carter-Thompson. That's the Carter-Thompson. Simply grab the suture and pull it out between the ribs. With the pericardium open and retracted, the next step is to enter the oblique sinus bluntly by pushing the Wolf sucker. This is from Scanlon, very low profile sucker, against the pericardium, and this will break into the oblique sinus bluntly. So we test before doing any ablation. This is baseline testing with the AtriCure bipolar device. This is a multifunctional device. We're going to use it here to do an epicardial electrogram. That's the second line on the blue screen. That's the right atrium. Then we'll check the superior pulmonary vein. There's signals in that. You can see on the second line. Then we'll check the right inferior pulmonary vein, and it's a second line, and then we'll check the bifurcation. And these squiggles should be gone after we do the ablation. This is high frequency stimulation to test for active ganglionic plexi. When we hit one, you get ventricular diastolic arrest right there. Atrium still fibrillating. This is a lighted dissector, the wolf light dissector. It acts like my finger going around the back of the heart. It articulates, and importantly has a light on the tip. The light will transluminate fat. And now we put the light dissector through the oblique sinus, bring it around between the superior pulmonary vein and the pulmonary artery. We pull the superior vena cava over just a bit, and there it is. And now we'll take the last little bit of tissue off the top, and that will allow the lighted dissector to pop through there, and then we will be able to remove the plastic, and then the light dissector can be removed. And there it is there. Plastic comes off, light dissector is removed. The plastic's connected to the red rubber. The red rubber is connected to the bottom jaw of the clamp. Now the clamp can be placed around the back of the heart by pulling on the red rubber. That protects the back jaw. And then with the sucker, we can shoehorn the whole clamp into the pericardium, close, and make our first antral ablation, which is here. And then we're going to get the ganglionic plexi, which you'll see here. We do a second clamping where we herniate that fat pad. So now we're on the sulcus terminalis of the upper jaw, and that gets almost all the ganglionic plexi except GP9, which is up underneath. After ablating with the clamp, we open the clamp, and then we use the pen to check signal, and we can see there's no signal in the vein there. So now the signal is gone, and we have entrance block. Entrance block has been achieved, so the clamp will now be removed, including the red rubber and the plastic part. You can see here the lines, an antral line posteriorly and more anteriorly along the sulcus terminalis, and that encompasses most of the ganglionic plexi except for GP9. This is key. Lastly, we use the clamp to create a line around the superior vena cava. There are some ganglionic plexi that come down innervation through the superior vena cava, and now we've made all the lines on the right side. This is a temporary pacing lead. It's a Medtronic bipolar lead, and this allows us to pace the heart intraoperatively and postoperatively for the first couple days, and the pericardium holds this in place. The pericardium is reapproximated with interrupted vicral sutures. You can also see the temporary pacing wire entering the pericardium in the lower portion of the screen. And now intercostal blocks will be performed using Exparel and Marcaine. Now we switch to the left side. The left side's up. This is opening the pericardium posterior to the left phrenic nerve. Anterior on the right, posterior to the left phrenic nerve on the left. We put stay sutures in again, pericardial stay sutures. We open the pericardium pretty widely, always being cognizant of where the left phrenic nerve is located. Open up all the way to the pulmonary artery and divide the ligament of Marshall. You can see right there. And then after testing, the lighted dissector goes around the back of the heart, up through the top, pull through the red rubber, which brings the clamp around the left-sided veins. And you'll see the clamp coming into position here. This is ablating the left side, and we verify that we have entrance block. usually 3 firings. They were verifying right there. Then the clamp can be removed. The next step is to create a line from the antral line well up onto the left atrial appendage using the bipolar pen. That's what you see here. From the antral line well up onto the left atrial appendage. And then the AtriCure clip. This is an AtriClip. This is the V clip. Very easy to place. We do it gently. Once it's in place, we fire the clip. And there's a view of the clip at the base of the left atrial appendage. The left side is pericardium is closed, similar to the way the right side was performed. And then we start, we're pacing now. We've defibrillated. Now we're pacing at 80 beats a minute. The patient's in rhythm for the first time in 5 years. We do a loop recorder at the end of the procedure, implantable loop recorder, and that completes the procedure. Okay, I'd like to interject at this point and remind people that if you have a question, don't wait till the end of the hour. Try to get it in now. Any question about atrial fibrillation is game. All questions will be answered if we are able to answer them. There aren't any stupid questions. We realize that this is for the lay public, so ask any questions you might like. And to do that, you can see there how to reach us. You can either use your phone, 37607, text DeBakey, or if you're on your computer, go to pollev.com, Pollev.com, and enter DeBakey and ask your question. Okay, Marcy put this next slide up, which is important. We go back to the slides. And I wanted to mention that third fat pad that Marcy has so nicely labeled here. I think actually Dr. Miranda labeled that probably.
Yes, it's correct.
I put Dr. Miranda on the presentation because he was instrumental in making some of these pictures look really nice, including the ones that are on this slide here. So that third fat pad is where the nerves are. And for those of you who've tuned into this webinar in the past, you know that we believe that the problem with AFib is an imbalance of the autonomic nerves. So our treatment is focused on treating these nerves, which are on the outside of the heart, not the inside of the heart. Catheter ablation attacks the inside of the heart and burns left atrial tissue, right atrial tissue. The Wolf procedure interrupts some of these autonomic nerves, and we feel that that's much more to the root of the problem of AFib, and I think you'll see that's borne out in the results. So we're not burning up the heart, we're simply doing a partial cardiac denervation of the autonomic nerves. The other one that I'd like to outline is in the top right, that's marked A, and those brown spots, the brown areas are where the fat pads are, and the black spots are the ganglionic plexi. These autonomic nerves are in these fat pads, and these are very nicely addressed with the Wolf procedure, which is represented by the green lines, both on the right side and the left side of the left atrium. And I believe that, and our hypothesis is that the reason this works so well is because we're doing a pretty good cardiac denervation. We're not doing a line to the mitral valve, we're not doing a floor line, we're not doing a convergent burn the back wall of the left atrium, none of that. We're not destroying any significant heart muscle, but we are attacking the autonomic nerves. And the last diagram on Marcy's slide here, marked B, is the areas where the ganglionic plexi live, and these are the specific areas that we target for partial cardiac denervation, and I usually record that in the operative report where we found the positive ganglionic plexi. You have anything to add to that slide?
I think you mentioned everything.
Okay, Marcia, I'll let you take over again.
Thank you very much. So it's very important to talk about how we collected the data and why is it important. First, on the right, you can see an implantable loop recorder, and you can also see the size. It's very small, which is very important, or was very important in our trial, because first of all, we could include 497 patients to this study. We included them from 2020 May to 2024 September.
So a fair number of these were during the pandemic.
Yes, that's true. Other than that, we followed these patients until 1 year, 2 year, and finally 3 year. And the strongest part of the study is that we continuously monitored over 90% of the patients with an implantable loop recorder or already existing pacemakers. The primary endpoint, so the points which we were most interested in, was whether the patient had less than 2% AFib or a flutter at 1 year, 2 year, and 3 years after the procedure. The secondary endpoint was whether they needed a follow-up catheter ablation to have a successful outcome.
So it could even be a patient who did not need anything at 1 year, but 2 years later they developed some atrial flutter and needed a follow-up catheter ablation.
Yes, it might have been the case, yes.
Okay.
We grouped our cohorts, the cohort of patients, to the type of AF they had, paroxysmal, persistent, and long-standing persistent. You cannot see the word permanent, because by definition, if you want to change AFib, then we're never using the word again, permanent.
So in general, patients that have paroxysmal AFib are patients where the AFib comes and goes, but they do have periods of regular rhythm, and the AFib doesn't last more than 7 days in a row or continuously, and they have not needed a cardioversion. Persistent patients are patients who have been out of rhythm for more than 7 days at a time. They still have some sinus rhythm, or they've had to have a cardioversion to get back in rhythm. And then the last group, long-standing persistent, by definition, are people where their heart's been out of rhythm continuously for more than a year. And this is important because we know generally this is a marker for the size of the left atrium. The longer they've been out of rhythm, more likely they have an enlarged left atrium. And we also know that the larger the left atrium, the more difficult it is to keep that heart in rhythm. Okay, go ahead.
Yeah, as you can see, this is a link, a monthly report actually. So on the left, you can see just a quick look. You can see the actual EKG, or the lastly recorded EKG of the patients. You can see how much of the time they were in AFib or a flutter, whether they had PVCs and such. And on the right, you can see actually a nice summary about the last 30 days on a monthly report. You can see how much of the times or how many days did the patient suffered AFib, let's say, or were in sinus rhythm, but you should also correlate these results with the ventricular rates and, of course, the symptoms as well.
So this is a report that we see on every patient every month. In addition, if there's an episode of AFib or a flutter that lasts very long, we also get a notification of that. So we can calculate the AFib burden from these monthly reports.
Correct. Yeah, and as you can see on the report on the right, this patient, for example, had nearly experienced any AF episodes in the last 30 days. Well, also we can see how many episodes, exact episodes, did the patient have. Let's say if it would start for 2 minutes, 40 minutes, 24 hours, we are going to see that. For example, this patient had not a single episode of AF after the Wolf procedure. The patient had 2 symptoms, but it was not correlated with AF, by the way. It's the same that we can actually retrospectively see the last 14 months, the rhythm of the last 14 months for each patient we have with the link. And as you can see, this patient had no single episodes in the last 14 months on the right.
I'll interject here as well. And sometimes it's difficult to tell before the surgery what the AFib burden is. So sometimes we place the link, the subcutaneous monitor. This monitor can be put in under local anesthesia on the chest, just with some xylocaine. It takes about 10 minutes to put one in. And sometimes I put these in to determine what the AFib burden is before we do the procedure to see if they really need the procedure.
Yeah.
Okay, go ahead.
So this is another patient. As you can see, the patient experienced some episodes for 2 minutes, 4 minutes, and even a longer one. And you can see also the rhythm of the patient in the last 90 days, and he experienced around 13 days of AF in this lifetime period. But if we can see that, as physicians, we can react. Other than that, if we would just have an EKG at 12 months and the patient can be in rhythm or out of rhythm, and you can react if the patient is out of rhythm. But in this case, we can react as soon as we can.
One of the points that we wanted to explore was what percent of patients who have this procedure really need a follow-up catheter ablation. In many places, this sort of procedure and a catheter ablation are done on everyone. But my hypothesis was a lot of patients who have this procedure don't need another ablation, or they don't need one at all if they didn't have one before. So one of our endpoints was using this information to see what percent of patients really needed both being the Wolf procedure and a catheter ablation. And we're about the only place in the world where we only do the procedure and not automatically tell them they have to have an ablation as well. So we'll get to that. Go ahead.
Also in our study, by the way, a follow-up catheter ablation, which was usually majorly different from the initial ablation, what you did or the Wolf procedure was not a failure, but as a potential part of the therapy.
Right.
So you can see our primary results. On the x-axis, you can see the incidence, how many patients had less than 2% AF or a fluttern at 12 months, 24 months, and 36 months. As you can see, the results are the best in the paroxysmal patients, even at 1 year, 2 year, and 3 year. It's around 96%, which is, I can say, excellent, but later on I think Dr. Wolf will talk about other studies as well.
Well, we can compare this to the open procedure called the Cox-Maze, and these results compare very favorably with the open procedure, which includes all types of lines across the heart and burning up the back wall of the heart and crossing lines and lines to the mitral. Well, we found we got as good or better results than what's called the gold standard without doing any of those other lines. But we did focus on the nerves on the outside of the heart. What Marcy's showing you here are the blue lines, the green lines, and what are those others? Kind of a
orange, let's say.
Orange looking line.
Yeah.
So the blue lines are patients who had atrial fibrillation, but they weren't out of rhythm all the time. The green lines at 1, 2, and 3 years are patients who had sometime normal rhythm, but they had had either episodes that lasted longer than 7 days, or they had had cardioversions. They have to get back in rhythm before the procedure. And the orange looking lines at 1 year, 2 year, and 3 year are patients who were out of rhythm continuously for more than a year. Some of them had been out of rhythm continuously for more than 5 or 6 years. And those results in those patients are rather spectacular. That what's the percent at 1? Let's go over the percents in this preliminary. At 1 year for paroxysmal, it's what?
96.
96% had less than 2% burden.
Correct.
2 years for paroxysmal.
Same.
3 years.
98, 95.
95%, which
it
is
didn't change.
Very, very good. And compared to catheter ablation, this is not 5 or 10% better, but this is 100% better. The green lines are the patients who required a cardioversion before the procedure, where we're out of rhythm for more than 7 days in a row. And what are those numbers, 1 year and 2 year and 3 years?
1 year, it's around more than 90%. Still, the success rates, it's kind of the same at 2 years, and it goes down a little bit at 3 years, but it's still around 90%, which is, again, for a group of persistent patients, it's very, very good.
Spectacularly good results. Now, here's a caveat. Some of these patients were done during the COVID-19 pandemic. They were unable to come back to Houston for follow-up, so some of them fell out. If they fell out and end up getting a catheter ablation with a pacemaker, AV node ablation, they were considered a failure.
Yes, correct.
Even though if they'd come back here, we probably would not have done an AV node ablation.
Yes.
We would have tried something else, but
Yes.
Some of them couldn't come back. But to be on the conservative side, we still called those a failure, even though they really didn't finish the protocol.
Yes, but in the era of COVID, probably they couldn't do much else, right?
Right.
Yeah, and you can see the orange lines. These are the most severe AF type, the long-standing AF. And even at 3 years, it was around 80%, the success rate, which is, compared to any other trial, it's still majorly different. Compared to catheter ablation in long-standing patients, do they even try to ablate those patients?
They do, but at 1 year, less than 20% are in rhythm. And for persistent, there was a study done here at Methodist, and it was part of another study. So those are patients that had had a previous ablation or cardioversion, and they did another ablation. And at 1 year, only 34% of them were in rhythm, versus we're getting over 90%.
Yes.
Yeah, big difference. Now, the other thing that's important to remember, this is almost 500 patients.
Yes.
That's a very large study. A lot of the study that was done at Methodist, there were only about 50 patients, I think, in the study, or 60.
Wow.
So this is a very large cohort. We can leave that up there for a minute. Again, if you have questions, get on your phone, 37607, text DeBakey. If you're on your computer, go to pollev.com, enter DeBakey, ask us the question. We take all comers. Let's take a few questions, Marcy. First one is, how long does the procedure take? It's done under a general anesthetic. It is a heart surgery procedure. It takes about an hour on each side to do the procedure. We do not use the heart-lung machine. We do not stop the heart. We do not give any blood thinners. So it's about 2 hours of operating time. It takes about 30 minutes for the patients to go to sleep and about 30 to 45 to wake up. So the whole procedure is a little over 3 hours, but the actual time of operation is about an hour on each side. What type of follow-up is done if a patient doesn't have the link monitor? Well, that's another good question. There are some patients who can't have the link monitor. Either maybe they have some other monitor in their body, or their insurance wouldn't pay for it, or they have some sort of government job that doesn't allow them to have a monitor in their body. We've had a few of those. Some of these patients have had pacemakers, which is still fine, and we can interrogate the pacemaker each month and get the same answers that we need.
Correct, yes.
What about the patients who don't have a pacemaker and didn't have the link?
Well, those patients, what I have seen retrospectively, is that they have an intermittent EKG report, or they can monitor themselves by smartwatches. That's an option.
Like an Apple Watch?
Yes, something like that, or transtelephonic EKGs, which is also, well, it's not precise, but at least if the rhythm is, well, messy,
Yeah.
then it can detect it, at least.
Yeah, and that was about less than 10% of the patients.
Yes, correct,
Yeah.
yes.
So not about 90% had the link, 10% had another form of monitoring
Yes.
for one reason or the other. You're never going to get 100%.
No.
90%
That's true.
is considered fantastic. How common is pleural effusion after the Wolf procedure? What is a pleural effusion? Let's answer what that is first in lay terms. A pleural effusion is a collection of fluid outside the lung but inside the chest. This is very common after thoracic surgical procedures. That's why we leave a drain in overnight after the procedure. And unbeknownst to most people, your body, as you're sitting there watching this presentation, is turning over fluid outside the lungs all the time. Your body turns over about 1 liter of fluid a day, where the fluid is secreted and reabsorbed by your body outside the lung but inside the chest. In some patients, it doesn't resorb at all, and you end up with a collection of fluid outside the lung. It happens in less than 5% of the cases. It's never zero. And if it persists, it can be treated by removing that fluid, generally with some numbing medicine and a needle. What type of follow-up is done if a patient doesn't have the link monitor? Well, the follow-up's essentially the same. We ask the patients to go on MyChart and send Kimberly Martinez, our nurse, the information that they have, be it a Apple Watch. Another common one is the Cardia.
Yes,
That's
Cardia.
with a K, not a C. Kardia. You can get it on Amazon Prime for about $70. They'll have it at your home in 48 hours. And in that one, you put your fingers on this little strip and you download an app for free, and it shows your EKG, a 2-lead EKG, on your phone. And there is a button for the Cardia where you can send that EKG by email to your doctor. So some of the patients did that, and you can do it as often as you want, but certainly probably a couple times a week is enough. But it's a pretty good way to follow this. We're not looking to see if some patients had a heart attack or something like that. We're just looking at the rhythm. So it's pretty good for the rhythm. It's really a pretty good way to go if you can't have the link. There are a few other ways, or those are the main ones, though, aren't they?
These were the main ones, including the smartwatches and including other transtelephonic EKGs. I think that was all. And some patients, a lot of them were refused to use these devices. They just went to their local doctor because most of the patients were out of Texas, actually. So they went there, did an EKG, and sent the EKG to our...
Now, our follow-up is pretty routine. The patients are seen 1 week after the procedure by me in the office. We check their link. If they don't have a link, we do an EKG. And then we check again 3 or 4 weeks later. If they're in rhythm, we talk about weaning from any heart medications. If they're not in rhythm, we do a cardioversion. It's not considered a failure if they have a cardioversion. It's not unusual for patients who've been out of rhythm continuously or who've had previous ablations to require a cardioversion after the procedure. Did that negatively impact whether they had a good outcome if they had to have a cardioversion?
Well, usually not. But what did it impact is that who received a cardioversion in the first 3 months after the procedure had more likely to have a follow-up catheter ablation.
A need for an ablation.
Yes, that's true.
All right.
Yes.
Let's see. What is the estimated percentage of Wolf procedure patients who've experienced pericarditis at least once since their Wolf procedure? Well, it used to be, when I first started doing this 23 years ago, it was a pretty high percentage. I think it was more than probably about 15%. So we scratched our heads and said we have to do something about this, and we added medicines post-op that decrease the incidence of inflammation around the heart sac. Pericarditis can be broken up to peri, which means around, and heart, which is the cardio, and the itis means inflammation. So it's literally inflammation of the heart sac. Very common after any type of heart surgery, by using steroids post-op, and also a very common, very old gout drug called coltracine. Initially, I did it for 1 or 2 weeks, and then some studies came out that the patient should stay on this medication. It's a pill once or twice a day for 6 weeks. And once we changed that to 6 weeks and the prednisone right after the surgery, we've gotten the incidence of post-op pericarditis to less than 5%. It's still not zero. And if it does happen, then we treat with another round of steroids and continue the coltracine, the gout drug. If that doesn't completely take care of it, we have a clinic here at Methodist. It's a pericarditis clinic, very thorough, and they have some other medications that they've used for a few of our patients. And having done all that, everybody has gotten over the pericarditis. But the short answer, it's about 5%.
It's correct. It's around 30 patients
30 out of
from
500.
500. That's
Yeah.
around 6%, yes, I
Yeah.
think. Yeah.
Let's go to the next question. Again, we will have a little more time for questions, so if you have not gotten your question in yet, please do it. 37607, text DeBakey on your phone, or pollev, POLLEV.com, and enter DeBakey and then ask your question. I'll take one more question right now. I've had 4 ablations in 14 years at Corpus Christi, Texas, and the AFib keeps coming back. I am a paradoxical patient and have had both cryo and radiofrequency. I think that patient needs to talk to us.
Well, I would suggest yes.
This is not unusual.
We had, so the patients who received the most preoperative ablations was, I think he had 8 ablations.
Yeah, so a patient who had 8 previous ablations
Correct.
came here and did well.
Yes. After that, it was a success, actually. Even at 3 years, I can remember that because I raised my eyebrows.
I can remember some of them, they were told they'll never be in rhythm again. They'll always have AFib. And we put the clamp, they come here, I put the clamp around the heart, fire at one time, sinus rhythm, which to me means that taking care of the nerves will really help. And unfortunately, the catheter ablation doesn't treat the nerves. It burns the muscle on the inside of the heart, but it rarely gets the nerves. And we believe nerves are what you have to get. The latest fad, if you will, is pulse field ablation, or PFA, and patients are told that's going to work when nothing else works. But they also brag about the fact that pulse field ablation will not injure the nerves. Well, I predict based on that, there'll still be failures with pulse field. And already I'm starting to see patients and have operated on patients that have had the Nirvana procedure, the pulse field ablation, they still have AFib. The midterm results of pulse field ablation versus catheter ablation is about the same. Catheter ablation with radiofrequency, really no difference in the AFib free rate. So far, it hasn't turned out to be better. It's faster and maybe safer. It doesn't injure any nerves, but I think you got to get the autonomic nerves to get success. So the answer is call 713-441-9342 or go to the Wolf Procedure website and answer any question there or send in a request for consultation. I do virtual visits. You can be anywhere in the world and we can get you in and talk to you. You don't have to fly or drive to Houston, the Texas Medical Center. We do virtual visits. Patients, if accepted into the program, only come to Houston one time. That's to have the procedure. We do all the other work over with a virtual visit, which has worked out very well. So I'd be happy to talk to you. And by the way, these virtual visits are just that. If I don't think you're a good candidate, then we won't recommend the procedure. So there's no harm done in getting an opinion. For some of you, it'll be a second opinion. You've never heard about this procedure before. And if you don't like what I have to say, or I don't think you're a good candidate, then we don't ask you to come to Houston. There's really no downside to getting a virtual visit. Then maybe work in a couple. We don't have a lot more slides, do we?
A couple.
So let me work in another question or two here. Can the procedure be done on someone who has a Watchman? That's come up before, hasn't it?
Yes.
And Marcy's smiling because we're looking at those patients. The answer is yes. And I've done several patients that have had a Watchman. And interestingly, when we test that left atrial appendage, it still has electricity. it's still active because the Watchman doesn't electrically isolate that part of the heart. When we do the Wolf procedure, we use a clip, we're electrically isolating that area because we're closing it off. But a Watchman is more like a cork in the orifice, in the opening of the appendage. So it can close the appendage, but it does not electrically isolate it. And what I've done is take the pen on these patients who have a Watchman and burn around the base of the Watchman during the procedure and render that appendage electrically isolated. So the answer is yes, and during the procedure we can electrically isolate that Watchman for you. And Marcy's looking into that, maybe a short presentation, a manuscript about how we do it, and maybe even what it looks like. So good question there.
Actually, in this whole cohort of the study, we had 10 patients who already had a Watchman.
We had 10 patients who had a Watchman out of the
497.
497.
But this is only 4 years.
Yeah, right.
The study
I've done
period.
more than that. Yeah,
Yes,
that's
correct.
What is the recovery time? Most patients stay in the hospital 2 nights. So the patient that was done Monday will be probably going out tomorrow. So Tuesday night, Monday night and Tuesday night. So it's usually 2 nights in the hospital, depending on what the heart rate is. And then the patients, if they're out of town, stay in Houston for another 5 days, see me about 7 days post-op, and then fly home or drive home, or if they're local, they just go back to their home. And then we do a follow-up visit at 4 weeks, and then depending on what their rhythm is, start weaning the medication. Usually another follow-up visit at 3 months, 6 months, and 1 year, and then annually. But as far as recovery, there are no restrictions. When patients leave the hospital, they're allowed to drive. There are no driving restrictions. There are no weight restrictions. I mean, you shouldn't go bungee jumping, but you can walk as much as you want. I talked to a patient today. We did last week. He's going to stay another day before they leave. They're going over to the Museum of Natural Science for the day. Some people go down to NASA. That's very interesting. Have you been there?
Yes.
Pretty interesting.
Thank you very much. Yes, it was a very good museum.
Some people go to Galveston, which is by the sea, the Gulf of America, which is about 45-minute drive from here. So people go out and do things. We're a mile from the museum district, and there are about 30 museums a mile from here, Texas Medical Center. What concern, if any, is there for experiencing PACs after the Wolf procedure? Is there a particular level of burden if one continues to experience PACs? Well, let's define PACs first. PACs stand for premature atrial contractions. Essentially, it means it's a heartbeat before your regular heartbeat. It's shoved in there between your 2 regular heartbeats, and they're considered benign. If they become particularly troublesome from the standpoint of symptoms, you can use a beta blocker as a medication, a calcium channel blocker. Sometimes those help. In extreme cases where they're so symptomatic, they just are incapacitated, an ablation can be considered, and this is done by the electrophysiologist. But in general, they're benign, and in general, a beta blocker is indicated to see if that settles it down. Generally not treated except in extreme circumstances. But if you're not sure if they're PACs or not, then putting a link in would be very helpful. And you can see, are they all PACs, or are you really having AFib or a flutter or inappropriate sinus tachycardia or POTS? There are a lot of other atrial arrhythmias that could masquerade as PACs. A link would help sort that out. And also, I believe that all these other arrhythmias that I just mentioned are probably all related to the autonomic nervous system. I'm approximately 10 months post-Wolf procedure. My heart rate has continued to be drastically lower than it was pre-surgery. I'm symptom-free. My understanding is many wolf patients see an increase in heart rate post-surgery. What factors drive the baseline heart rate response post-surgery? Is there any medical importance to heart rate reduction versus heart rate increase post-surgery? Well, we are modifying the autonomic nerves. It's not complete, it's partial. And some of these nerves speed up the heart and some slow down the heart. I believe your heart's happy to beat 60 beats a minute your whole life, but it's influenced by these nerves that come from your brain and from your spinal cord. And generally speaking, if the heart rate is lower after this procedure, you're almost always assured of a really good outcome.
Yes.
You're not going to get that real fast heart rate and AFib. Normal is considered 60 to 100, but that's very arbitrary. There are a lot of people running around with a heart rate of 40 to 50. My own heart rate's about 50. I guess you could say, gee, I need a pacemaker because it's less than 60. But if you don't have symptoms, don't. Neil Armstrong, the first man on the moon, once said, you only have so many heartbeats, so don't use them all up right away. I don't know if that's right, but we got a few more questions. And I think we better go back to the slides, make sure we finish the slides first.
Yes, thank you very much.
So we'll go back to the slide just for a minute or two here.
This is another important slide. You can see that how many patients who were successful, so they had less than 2% AF burden at 1 year, 2 year, and 3 year, needed an additional follow-up catheter ablation. In the paroxysmal group, you can also see even at 1 year, 2 year, and 3 year that the numbers are very low. Paroxysmal patients will usually not need a follow-up catheter ablation to have a successful outcome. Although on the other hand, the most severe group, the long-standing persistent group, did require a catheter ablation. Of course, it was the highest number at 3 years, which was also 25%. But those patients who needed a catheter ablation ended up successful, in rhythm-wise.
And I'd like to turn this around. So if you go to a program where they say you have to have a catheter ablation and a surgical procedure, we could say, well, do you realize in 75 to 92% of the time that catheter ablation wasn't necessary based on this information?
Yes.
Because the majority of patients don't need the catheter ablation. No. Even out 3 years, even in the most severe cases, it went up to about, a third of them?
No, well, around 25%.
25,
yes.
A fourth of them?
Yes.
Only a fourth of them needed an ablation?
Yes, correct.
So we're saying, do you really need to do an ablation in all the patients that have surgery? We suggest maybe you don't. Okay?
Well, we have other very interesting findings as well. The stroke rate was very low as well. And actually, we are looking at predictors of a follow-up catheter ablation now and the predictors of surgical success, but I can't talk about anything. You have to read the paper as soon as it gets published.
Yeah, so as Marcy puts here, to be continued, there's a lot more information that we're dealing with, and we're going to have some very exciting conclusions, I predict.
I hope so.
Yeah. Now, we got a few more minutes. I'll try to get through a few more of these questions. How does the Wolf procedure differ from cryo and RF? It's 100% different. We're not burning up the heart tissue. We're not freezing the heart tissue. We're taking care of mainly the nerves on the outside of the heart. We do isolate the pulmonary veins, but the main goal is to isolate these nerves and do a partial cardiac denervation and close the left atrial appendage, which means our patients don't stay on blood thinners anymore. Even if they're out of rhythm after the procedure, they don't have to be on blood thinners. Can a patient get an MRI after the devices are installed? Magnetic resonance imaging? Yes. Everything we do is MRI compatible. None of the things we use have iron in them, and that's what you have to avoid with an MRI. So the answer is yes. How soon can I stop taking blood thinners after the procedure? We don't restart the blood thinners after the procedure unless the patient has a history of a stroke and we continue the blood thinners for 1 month. But generally, we don't continue them at all. apixaban or Eliquis only has 60% protection against stroke. That's true. It's not 100%. Some people and some patients have this delusion of grandeur that if you take a blood thinner, you won't have a stroke. The reduction's about 60%, and you've got the side effect of possible bleeding. That's another advantage of what I do. We close the appendage, you're done with the blood thinners, and you have a 97% reduction in stroke. You took one off of there. University of Wisconsin recommends blood thinners even after AtriClip. Well, we will cordially disagree. Cardia, 1 or 6 lead recommended. Just the 1 lead. We're just looking for the rhythm. Temporary junctional rhythm normal after procedure. It's not uncommon in what I found, and my protege in Tokyo, Dr. Otsuka, have both found that if you have junctional rhythm after the procedure, you almost never have AFib again. So it's not a bad thing. Clinically proven allergy to nickel make any part of this procedure prohibitive? No. Are there any studies that compare results of Wolf procedure to the convergent procedure? Not that I'm aware of. And none of them have the link in either. How does the Wolf procedure compare to AV node ablation? Oh my goodness. AV node ablation and pacemaker doesn't stop your AFib. You'll be in AFib all the time, and your God-given pacemaker will be burned out. You'll be completely dependent upon an electrical pacemaker, and 25% of those patients get what's called pacemaker heart failure. I don't recommend it except under extreme circumstances where there's no way to get the heart rate down under control. But you ought to consider the Wolf procedure because the pacemaker doesn't result in sinus rhythm at all. And you still need blood thinners. Is there a benefit to staying on beta blocker? I think so. Low dose, half of a 12.5 a day. I think it's helpful. Blood thinner stopped immediately after procedure, yes. What would make someone not be a good candidate? Usually they're too large. If your BMI is greater than 35, from a technical standpoint, it's difficult to do the procedure. Also, if you've had a previous mitral valve procedure, it's usually technically not feasible to do the procedure. You have so many patients, how do you monitor all the loop recordings? Well, what we do is we use a third party here at DeBakey, and that third party's job is to look at all the people that have implanted monitors and alert the physicians to the ones that look like there's something going on. So it's part of a much bigger program. Loop recorder showed 6 seconds of conversion pauses last 24 months. You recommend a pacemaker? No. Before the Wolf procedure, no. And we only recommend a pacemaker if you pass out. Because if you cardiovert yourself, it's normal to have that pause. That's called a compensatory pause. And you'll get a little dizzy and then you'll be okay. It's all right. Burden between 1% and 2%. Do you need an antiarrhythmic? No. Is there still hope for those with enlarged left atrium? Yeah, I've done patients within the last year with an atrium of 265 milliliters, and we still get sinus rhythm, but it's not going to be 90% chance at 3 years. It's going to be more like 75.
75, let's
75% chance. And let's see, never had an ablation, never had a cardioversion, 9 episodes in the last 4 years, 7 months since my last episode. Maybe you don't need anything, but if you want to know your real AFib burden, have a link put in. Find out what your AFib burden is. If it's less than 2%, I probably wouldn't do anything. If it's greater than that and you want to get off blood thinners, then we should talk. Go to the Wolf procedure, fill out the form, we can do a virtual visit. And let's see, heart rate response. Post-surgery, we want it to be blunted. That means we did something. If you have a lot of heart rate response, that's not good. Okay, I think we better, let's see, how much pre and post-op consultation can be done virtually for out of state? All of it.
All of them are
All
done.
of it.
Nearly all
And
of
that's
them.
what you did.
Yes.
You noticed that. So we're up against the time. We'll probably have another one of these first Tuesday of next month. I want to thank Marcel for all the tremendous amount of work you've done to try to bring this to fruition. Thanks for taking a